Hello and welcome back to the show. Sustaining the NHIS is 10 years on, and we're looking at what's the way forward. How can we sustain it for another 10 years and even furthermore? Joining us on the phone later will be Dr. Steve Mantia, who's the campaign coordinator of ISODEC, to also express his opinion on the scheme. And these are guys with authority with me in the studio. I've already introduced him as Sylvester Mensah, who's CEO of National Health Insurance Authority. Sylvester, welcome to PM Express.
It's my pleasure to be on your program.
No, have you seen you on my show before?
Yeah, this is my first time, and I'm happy to be here.
Sylvester, before we even go into the NHIS, right? Now, my issue is your position is a political appointment. And so if anything went wrong with your organization, i.e. government wasn't giving you the money or the logistics, it makes it difficult for you to jump on the platform and scream up and down and cry foul, because of the nature of your position.
Well, let me start by saying that the National Health Insurance Authority is 10 years this year. It is important, first of all, to commend and salute
We're going to get there. We're going to get there.
The promoters of the law that eventually brought the National Health Insurance scheme into being. I think that it was a very bold effort, a very courageous one, and the foundation has been laid. It is our responsibility, you and I, to deepen the process and ensure that the purpose for which it was established is achieved. But in doing so, it is also important for us to appreciate that it is a process. It is not a single blow event achieving, as it were, financial risk protection. And we cannot say that at this material point we have come to the end of the road by way of achieving the ultimate objectives of the establishment of the health insurance scheme. It began slowly, and there has been progress over the years. We still have a long way to go. We want to shorten the road and ensure that in the not too distant future, we should be able to say together that yes, we have been able to make the mark, we have been able to achieve our purpose. But for today, we are on a journey.
Well, since you've answered my second question, so I go back to my first question, because that was going to be my second question. So my first question is, the process, the idea, everything is beautiful. I don't think anybody will fault it. I am saying, and it's not your fault, it's not your fault, but your position as the overseer of this institution is political. You depend on political powers in government to help you run the institution. So if anything goes wrong, how then do you jump on the platform and scream so that we come to your aid, i.e. the media or civil society?
Well, let me say that within the context of the law and perhaps the Constitution of the Republic of Ghana, I am an Article 95 officer, just like any civil or public servant. All directors you find in the ministries are appointed on the basis of Article 95.
Article 95.
It has to do with the appointment of public officers. So it is a position for technocrats, and it's a position for a certain level of, as it were, competence and talent for managing not only the civil and public service. So essentially, I am a public officer, and my appointment, as derived from the law, comes from the Public Services Commission. So and it is the president who appoints that position, who appoints one to that position. So to the extent that all directors you find in the ministries and in the other agencies are appointed by the president, yes, I am an appointee of the president and an appointee of the Public Services Commission, which makes me a public servant.
So was that 10 years? You sit in your office, you open your door and you sit down, you look in your book. Are we where we're supposed to be? Are we behind, or are we ahead of 10 years?
Well, I think that is what I expect you to tell us. At the end of the day, we are commemorating 10 years of health insurance in Ghana.
Mm-hmm.
We never said anywhere that we are celebrating 10 years. We are commemorating 10 years. It is a time for, essentially a time for reflection, a time for taking stock, a time for, as it were, gathering knowledge and redefining the way forward. And as a result, as part of this commemoration, we are having what we call commemorative lectures. We're having 2 lectures to that effect. One lecture would be delivered by Professor Irene Japon of the School of Public Health, Legon, and we are expecting the Deputy Director General of the World Health Organization, Mr. Ban, to also deliver the second lecture. The whole idea is to set the tone for some academic and operational input into our operations. This will be climaxed with an international dialogue session, and it's an international forum. We're expecting well over 120 foreign guests from over 100 countries. We are looking at not only academicians, but experts in the field of health insurance and the health sector in general, and also countries trying to, as it were, also learn from what is happening within the community of health insurance nations across the globe. So essentially, the purpose of commemorating 10 years is to take stock and reflect on the past, and as you could infer from the theme, achieving universal health coverage, with a sub-theme increasing or improving enrollment and ensuring sustainability. You could see clearly that there's an inherent conflict in increasing enrollment and ensuring sustainability. And these two are our key challenges as a country, as National Health Insurance Authority. We set up this theme to offer an opportunity for all those who will be delivering papers and making contributions to focus on these key areas. So at the end of the day, we'll be able to gather enough information, enough knowledge, enough experience from several countries to inform the redefinition of our way forward. So we are saying to Ghanaians that 10 years of national health insurance in Ghana, it is a journey. We haven't gotten to the destination, and we are taking stock of the 10 years.
Let me take you a little back before we get here. I asked, in commemorating your 10 years, I was wondering if you had achieved, exceeded, or exactly where you went, and then you wanted to find out from the general public what you've done. But have the National Health Service, do you have targets to say that, oh, in 5 years we need to attain 5% of the population, in 10 years we need to do 50% of the, I mean, you must have some internal targets.
Oh, certainly you cannot run an institution and a project
very good.
Of
so
this nature without
in 10 years,
target.
your targets that you set, how far behind are you, or far ahead are you on your targets?
Well, let me start by saying that there are a number of lessons that we have learned over the period. And in particular, when we have foreign guests coming over to Ghana to learn from our experience, we have shared with them experiences that they should not, as it were, go through at all as a country. Particularly with regard to the benefit package, we have always insisted that countries learning from us should not necessarily learn the generous nature of our benefit package, which covers about 95% of disease burden in this country. It is always useful to begin on a very modest note and gradually increase the benefits under the package as you assess your inflows and financial strength, in order that you don't go through the road that we have gone through. I think that we began with a rather generous package The intentions were quite laudable and commendable, but the financial muscle to sustain such a huge benefit package has been quite challenging. So indeed, we have a challenge when it comes to sustainability, and that has been a problem deriving from the general architecture, the molding blocks of our health insurance scheme. So starting from that angle, what I'm trying to put out is that we began on a rather huge note, and we are currently confronted with the challenge of that, which of course is a lesson for other countries. But having said that, we began with an active membership of about 1.3 million in 2005, at a time when utilization was just above 2.5 million. And by utilization, we're talking about the number of people accessing healthcare using their health insurance cards. And then in 2000...
You said 1.3, and then access was 2.5.
Active utilization was about 2.5.
So I don't understand. Is it 1.3 million?
1.3 million
members.
Yes.
So how were 2.5 million using it if you had 1.3? I don't understand that.
Well, you have an active membership of 1.3 million, and you have about 2.5
on
people.
the scheme. Okay, I understand.
You have 1.3 million people as active members on the scheme, and you have a utilization, an aggregate utilization of about 2.5. By implication, some may go to the hospital twice a year, some may go 3 times a year, others may not go at all. But cumulatively, you have over 2 million people accessing healthcare using the health insurance card. Around 2008, the utilization rose to around 16, 17 million. And by the close of 2012, utilization had risen to near 27 million, 26 point something million. Now, the general...
Are you sure of the figure?
Yeah, very sure of the figure. The general... I'm talking about utilization. I'm talking about the number of people who accessed healthcare using health insurance card.
Let me break it down. So in 2012, there was 26 million visits.
Visits to the hospital.
Visits to the hospital.
Yeah.
Okay.
And that is what we call utilization.
Okay.
People who have accessed healthcare. One person might have gone 2 times. Of course, with free maternal care, you have expectant mothers visiting the hospital between 5 to 7 times, perhaps. So, yes, these are the figures, and these are accurate figures that I'm mentioning. Right. So, judging from what is known as the key performance indicators, then one can say that public confidence in the scheme has been growing year on year, and that the growth has been phenomenal. But having said that, it is also important to look at the active membership within that same period. If active membership as at 2005 was 1.3 million, by the close of 2012, active membership had risen to close to 9 million. When we talk of active membership, it's important to make a clear distinction between active membership and general membership, because one may register, have a card, and may not renew the card to be able to access healthcare. It's just like being a member of a professional body and not renewing your subscription. So you are not an active member, and it's only when you renew your subscription that you become an active member. So generally, when you look at the active...
9 million people went to the hospital, basically
26
million times.
That's right.
So maybe everybody went like 3 times or something.
Right, yeah, an average of 3. Yeah.
Is it a good average? I mean, 3 times in a
Well,
year is not too bad.
Yeah, it's not too bad if you compare that to other countries. Because what is missing in our analysis, in our debate, in our discussions has been the lack of a benchmark for people to be able to properly and effectively assess the performance of Ghana's health insurance scheme. We only look at our internal situation, and of course, there's nothing wrong with wanting more than what you are receiving. But if you put that against international best practice,
So what,
you put that
at the moment,
against...
currently, what percentage of the population are on your list as active members?
We have about 36% of the population as active members.
Active.
So, yeah, so these are members who...
With valid cards.
Who have not only registered and have a card, but who have renewed their registration and are eligible to access health care with our cards.
And these 9 million, are these 9 million of the privileged or 9 million of the underprivileged?
Well, the health insurance scheme, the general architecture of the scheme has an inherent mechanism to rope in the poor, the underprivileged, and not-haves. It's important to appreciate that health insurance schemes are usually for the benefit of the poor, the not-haves, the vulnerable in society. And we have an exemption category. All those who are below 18 years are exempt from the payment of premium. And if you look at our current demographic figures deriving from the last census, those under 18 years constitute almost 46% of the population. We also have all those 70 years and above exempt from the payment of premium. Mm-hmm. We have...
so what percentage is about 10?
We have about, pardon me?
70 and above is about 10%?
It's less.
It's less?
It's less than 10%.
Less than 10%.
And then we have our expectant mothers or pregnant women also exempt from the payment of premium. And then we have LEAP beneficiaries or the poor, all exempt from the payment.
How do you determine who's poor?
Well, we have a means test mechanism at the scheme level, and I wouldn't say it's a perfect arrangement, but through discussions, interrogations, where do you work, how much do you earn, our premium is graduated with a lower end of 7 cedis, 20 pesos, and at the apex we have 48 Ghana cedis.
48.
So yes, so we have this continuum within which our schemes determine how much an individual...
So out of the 9 million people, the active members, what percentage of them are paying and what percentage of them fall within the bracket of not paying?
Well, looking at the exempt category that I have just mentioned, we have almost 69 to 70% belonging to the exempt category. And so you have about 30% from the informal sector as premium paying members.
So basically about 3 million active members are paying.
Great.
The 6 million are there for free.
Of course. That is the nature of our scheme, and that is how it's been structured. In fact, the whole purpose is to ensure that as much as possible, the poor, in whose interest health insurance schemes worldwide are instituted, are roped in. And so this mechanism is perhaps peculiar to Ghana, and it is one of the major features of our scheme that most countries really come over to study and to, as it were, adapt in the establishment of their health insurance schemes.
You must have a big headache as to how do you sustain the system. It's practically free. You know, and I know with an insurance scheme, even though you don't pay there and then, somehow you pay via the back end. But here are most of the people on the scheme can't literally even afford to pay via the back end, and they can pay it from the front end. So where are you funding this money from? I know 70% comes from taxes and everything. But up until when? Is it going to be like this
Well,
forever?
we have two key models of insurance schemes. We have the social health insurance scheme, which subsists largely on the payroll deductions, and that is what we mean by social health insurance scheme, subsisting largely on the payroll deductions. That is at one extreme end. And then we have the national health insurance scheme, which subsists largely on tax revenue. We have a mix of these two concepts, and so we are in between the social.
Is it sustainable, or we need
national.
to find another way out?
That is a question for government.
You are government.
We are an agency under the ministry.
Article 95.
We are an agency, just like any director in any ministry. We are an agency under the Ministry of Health.
And as
we
an
have,
agency,
let me put it this way.
You are there, so I come to you and say, Sylvester, this is government. Is this system that I've given you, is it sustainable? What do you tell me? What your advice do you give me? Yes or no?
It is sustainable to the extent that government is ready and willing to fund through tax revenue. And I must say,
giving you 70%.
Pardon me?
The government is giving you 70%. You know, you're out of
we
your
are looking at
expenditure.
you are looking at a social democratic government that has as part of its objects to ensure that there is some social protection for not-haves in society, and it touches the very core of the political philosophy of government, a social democratic government. I mean, what aspect of the needs of our people is government absorbing? And if government decides to pick health as one of its key targets, because, of course, the health of the people determines the wealth of the country. And so, yes, government is, as we speak now, government is reviewing this structure. A number of recommendations have been submitted to government, which has to do largely with additional inflows and other related programs. But let me say that
government is 8.7 billion upside down in debt, you know, and there are other challenges, energy and everything. Health is very important. I am saying that we need to go forward, but how? Because clearly what you're saying is that the system that they're giving you now, very soon or later you fold up and say, look, that's it, I can't go further. So, and this is a social democratic government, as you so put it, which is very good. But the will and the ideology alone is not enough. We need to back it with funds. So what are some of the things that you have proposed that, look, unless we go this way, we are out of business?
Of course, you have heard, I guess you have heard us indicate time and again that it may be useful to increase the NHI levy. We've also made proposals to the effect that those exempt from the payment of VAT should not be exempt from the payment of NHI levy, so that we can rake in a lot more resources. We have spoken and also communicated the idea of sin tax, that is taxes from alcoholic beverages and cigarettes and tobacco and a host of others. And as I said, government is considering a number of proposals that we have submitted. I'm not sure I want to go into the details of that proposal because government must respond, and the response will form the basis for discussion. But I must say that as managers of the health insurance scheme, we are not oblivious to the challenges that you are currently putting up. But at the same time, it is important that we manage the scheme efficiently until, as it were, these proposals are responded to. And that is exactly what we're doing.
I think my viewers...
But you could also see from the theme for our 10th year commemoration, we're talking about increasing enrollment and ensuring sustainability. We could tell clearly that this is a theme that would generate a lot of discourse, a lot of discussion, will generate a lot of knowledge, will bring together experiences from other countries.
So
and I believe, that by the end of the, as it were, international policy dialogue that we are organizing, we would be able to enrich our own knowledge and with the experiences of other countries,
all the problems
to inform
confronting
our way
you,
forward.
With all the problems confronting you and the suggestions you made, what informed one-time premium?
I'm not sure one-time premium is on the menu for discussion. As you are aware, His Excellency the President last year.
No, I'm sure once viewers have seen you, I'm sure they would want to know.
But, well, so let me say that you would recall that sometime in the last quarter of last year, His Excellency the President directed that the Ministry of Health and the National Health Insurance Authority engage stakeholders on the subject matter of one-time premium and to sustainability, and submit recommendations for action. The position of stakeholders at that forum, which brought together stakeholders from all, far and near, and also international speakers and guests, the forum concluded that one-time premium should be set aside, and that recommendation has been submitted to government. As we speak today, one-time premium is not on our menu, and I think that we can put any discussion on one-time premium aside, as it is not part of our menu going into the future.
Okay, so that's set aside. Now the next question will be, we have 9 million people who are active members. And these guys are coming in and out of the hospital 26 million times. Out of that, government needs to give you 70% of your total money from taxes, social security and everything. And it's a strain. Do we go quiet on trying to rope in more people and see how we can strengthen the system and then gradually rope in more people? Or for our 10-year celebration, do we go out and say, listen, this is a good benefit, come in and join? Because clearly, everybody coming in to join now is coming in penniless. They don't have the money. The people in airports and Laboni who can afford your system, they don't need their advert. So this campaign would go to the Kudi Kope and the rural areas who can't come. They'll come in penniless. So, at this stage, I don't know. Do we just go quiet, strengthen what we have, and then gradually rope in, or do we go and say, look, we are trying to increase and sustain? Where's the balance?
Well, we have done some research, and we've also tried to monitor the use of the facility across the country. Now, what is quite intriguing is the fact that, yes, we have an active membership of about 9 million, which is right about 36% of the population. But if you go to our facilities, visit any of the particularly public facilities anywhere in this country, and you would observe that over 95% of all patients you find in the hospitals are health insurance subscribers. So yes, we have a 36% active membership, yet you go to the hospitals and the public hospitals, you have 95% and above patients, health insurance subscribers. You go to the private facilities and you see over 80% being health insurance subscribers. The general impression from this is that perhaps all those who need medical, or perhaps most of those who require regular medical attention have enrolled, and they constitute the active membership. The bulk of our people who are generally healthy perhaps are among those who have not enrolled or perhaps not renewed their membership. Because if you want to look at membership, those who have owned a card one time or the other, that number is well over 22 million. Of course, there may be some duplications, double registration, and a host of others. It may be difficult at this time to, as it were,
there's no system to monitor, find out is the same card being renewed?
Yeah, it is. We are now updating our system to address some of those, and that is the reason why we have introduced instant issuance of ID cards based on biometric data as a way of ensuring data integrity, cleaning up the system, and vouching for the integrity of the data that we have.
I have Dr. Steve Mantiao, who's a campaign coordinator for ISODEC, and they have, reservations on your system. Doctor, good evening.
Good evening, sir.
Well, today we are looking at how we can sustain the NHIS. I mean, it's 10 years this year, and obviously we need it for another 10 years and more. And I know you guys have done a good report about, some of the things which, you don't think it's sustainable if you run it this way. What are some of your reservations?
Well, thank you very much for the opportunity to share my perspective on the matter for discussion this evening.
Thank you.
I think we need to recognize the responsibility of the state to ensure that every citizen, regardless of your social status, that you are able to access affordable health care. It is a fundamental principle underlining the social contract that exists between citizens and their governments. And it is because we cannot, as individuals and households, provide our own healthcare facilities. We contribute taxes, so the state will provide these for our collective use. And so when we get into a situation where we're considering healthcare or healthcare delivery, we need to actually underscore the fact that the primary responsibility rests to the state and it has to be financed from taxes. You can then supplement the funding if you think what you are deriving from taxes are not adequate in ensuring extensive or wider coverage. Now, we find that currently, under the regime we have, the National Health Insurance is being financed through a combination of premium that people pay,
yep,
and then as well as, to some extent, I would say taxes, because these are social security contributions and a certain portion of VAT.
Yeah, I give you the breakdown. I think premiums are 5%, social security is 25%, and 70% basically from taxes.
Yes, then I'm saying that there is a mix of sources of funding. But the challenge we've had over the years, and I think, one, I need to say that it is a good idea that as a country, we thought through it and we designed this formula for trying to improve on healthcare delivery. But the current agreement will not ensure universal coverage. So as we move along progressively, we need to actually look at how we are able to cover those who are currently not covered. And here I'm referring to the indigent, the poorest of the poor, who actually cannot afford to pay even the smallest or the lowest of the premiums that we have currently. So it is still a challenge. And for me, one of the areas we want the government to be looking at would be, first and foremost, getting the rich and those who are higher on the economic ladder to bear a greater portion of the cost of delivering healthcare in this country. That is to say that you could be targeting goods and services consumed by these people, the rich in society, for higher taxation, and these taxes could go to supplement whatever we have currently for the NHIS. And specifically, we're looking at, for instance, alcoholic and beverages as well as tobacco.
Okay.
We also could be looking at property taxes, taxing those who live in affluent areas much more than those who live in poorer areas and all that. And then ensuring that a certain percentage of the taxes you collect then go to supplement. So currently, I don't think it will suffice to rely on the current formula we have, the VAT plus premium plus state contribution. I don't think, and there's a study that I've seen that suggests that about 30% of the population who actually are enrolled, 30% of those enrolled on the NHIS are consuming about 80% of the total collection. And if that study is true, I mean the report of the study is true, then it actually rings the alarm bells in terms of what happens if we get a higher enrollment levels, let's say about 60 to 70%. Then there's no way the current revenues can support the scheme. So going forward, we need to really be looking at more ambitious tax mobilization mechanisms, but one that actually is pro-poor, that does not target the poor, but target the rich in society to finance the health scheme we have currently.
Doctor, let me...
We'll also be looking at the mining sector, because mining activities and oil activities as well also affect people's lives. And so, to the extent that the impact on the health of people living in the host communities, you want to be able to get these companies to also contribute a little bit towards the health delivery system. We could also be looking at all other activities that have health implications for taxing for the purpose of helping finance health delivery in the country.
Thank you, Doc. Let me come in here. You see, I've seen all your areas where you are taxing, and it seems to be the same old sitting duck. The guy in airport, the guy in cantonment, but the guy selling coconut is probably making 1,000 cedis a week. But, we don't seem to want to widen our tax nets to include these guys. It's always the usual guy who imports something to Temba Harbor so he can run, or somebody who is at the port. Can't we try and widen the tax nets rather than squeeze the same old proverbial formal guy?
I do agree that we need to widen the tax net, but it is not entirely correct to suggest that the guy selling coconut does not pay tax. Okay? There are various types of levies that they pay. Go to the market tolls and other levies that are imposed on these people. Sometimes I think it becomes too much of a burden for these people, because most of these people, you need to really recognize, are not on social security schemes. They have no pension in future and all that. And so, to some extent, yes, they are paying their taxes. Let us not suggest that there are the low-income people are not paying tax at all. VAT is a tax that everybody pays, regardless of whatever you do. And I think that it is in a way also targeting the poor, because both the poor and the rich pay VAT. In addition, those in the market and in the informal sector also pay all manner of levies. And these all could go and count for taxes. And so, for me, it is not entirely correct to suggest that, yes, we are overly targeting the very few. What I think we should be doing is to look at big businesses, look at those, not the average income earner, but those who are actually earning above average. And those are the kinds of people I'm referring to, not the civil servants, the public servants who are already overtaxed and actually take on very little.
Doctor, hold on for me 1 second. Silsa, it's been 10 years down the line. So why haven't we taxed all these guys till today? Why are we now going to look at taxing them? I mean, alcohol, whiskey, black label, all these big boys drinking their big drinks. Why haven't we taxed them? It's 10 years down the line.
I think you are asking the wrong person. I am the chief executive of the Health Insurance
Have you
Authority,
proposed it since 2009?
And I'm not sure that it lies within my purview to tax. But of course, I believe that the purpose of this discussion is to throw up ideas and get our viewers to listen, and of course, for those who are key stakeholders and who have a role to play to also listen. In fact, the whole purpose of commemorating 10 years is for discussions of this nature. I must say that health insurance has never said that it knows it all. It's a virgin path, and as you can see, in the whole of Africa, there are just about 3 countries that are running the kind of scheme that we are running, and so we are blazing the trail. And of course, we have lessons to learn, and others would have to learn from our mistakes. But having said that, ours is not to make too many mistakes, because we can't afford the cost of such mistakes. I think that we are progressing steadily. We are making progress. New ideas are being thrown up. Proposals and suggestions are going up to where they should get to. And I believe that 10 years would mark a new beginning for Ghana's health insurance scheme.
We're going to take a break, and then when we come back, we are looking at how we're going to sustain the NHIS system. Stay tuned. Welcome back, Star Ghana and Multimedia in conjunction, keeping the peace. We still need to keep the peace, you know, after the tension and the trials and everything is over, we still need to keep the peace. Sustaining the NHIS 10 years on, with me on the phone, Dr. Steve Mantiao. In the studio is Sylvester. Now, Doc, have I got you on the phone? Hello?
Hello?
Yeah, Doctor.
Yes.
Now, you put in some brilliant ideas, you know, taxing mining companies, which I think, you know, we by all means need to go for them. Probably even the new oil companies that are coming, we need to. But I mean, after 10 years, with these basic, brilliant suggestions, I mean, what is keeping a nation from launching into such a thing to get money?
Excuse me, your line is breaking, so I'm only getting snippets of what.
Sorry, let me raise my voice if you can get me. I said you raised some brilliant points with regards to ways in which the nation could get money to fund the NHIS. But even though they were brilliant, they're very basic, i.e. taxing luxury goods and companies that make a lot of money. Why is it that after 10 years, you know, we are talking about it rather than something that we should have done ages ago?
Well, I think it is never too late. I agree with you. This is something we should have thought through. If you go to most of the mining areas, you see that the predominant illness is actually malaria because of the trenches that are dug and left uncovered and left to collect waters and become breeding places for mosquitoes and all that. There are also other diseases that affect the skin and all that as a result of exposure of hard metals and stuff like that. So there are a number of environmental health concerns that come with extractive activities that we need to take into account. And I don't think it will be out of place really to ask mining companies to contribute at least. If we're not at all, it is a better way of demonstrating their corporate social responsibility to society and all that. But then it didn't come at the beginning, but it is coming now. And 10 years we are reflecting back and seeing what we did right and what we did wrong. I think it helps to really consider these opportunities as areas that we could tap on more resources, tap into more resources to make the NHIS better. I don't think it's too late. Yes, we should have done it earlier. We didn't do it, and so is it too late? No, it's not too late. We can still do it.
Do you think it has been too politicized?
The NHIS, I do not think has been politicized. I think I give a lot of credit to both the NPP and the NDC because I think the NPP started it and the NDC came, they've not scrapped it, they're looking for ways in which they can make it better. And I think we all as members of society have a responsibility to contribute to our ideas in terms of how we can identify new sources of funding to make it more efficient than it is. But while we look for new sources of funding, I think we should also be thinking about how we can eliminate waste and abuse in the system, because no matter how much money you find, if there's a waste and abuses in the system, there'll still not be enough money to be able to finance the scheme.
Let me get Sylvester here. 30% using 80% of the resources. Are the doctors or the providers, you know, adding extra names, or genuinely 30% are using 80% of your resources?
Well, I haven't had this report, and perhaps I'll need this report to study, and it is only then that I'll be able to make an informed comment.
But you don't need a report, because you only have 9 million active members, and you're very, very stretched. So even without the report coming, you should know that if 9 million is 30% of the population, and they are stretching up, you know, using up all your, you know, your money.
It depends on how you want to look at it. Because I had indicated earlier that from our observation and monitoring, we have observed that when you go to the public facilities, over 95% of patients you see there are health insurance subscribers. When you go to the private facilities, you find over 80% health insurance subscribers. Now, if we have 36%, 9 million people as active members, and yet you go to the hospitals and 95% of the sick are, health insurance subscribers, I mean, what does that tell you? It tells you that perhaps there's something wrong somewhere, to the effect that most of the people we have on our list are those accessing healthcare. By implication, perhaps increasing the membership may add just marginally to our cost, because most of those people who have not, as it were, renewed their registration, even though they know the value of renewing their registration, are people who generally think they are so healthy. Of course, those within the age bracket of below 18 years are generally healthy people who do not necessarily visit hospitals like
Let
the
me just round up
elderly.
with Dr.
So generally, I think that there is a confounder somewhere that we all need to look out for. But generally, I think that from the trend over the years, there has been a steady growth in active membership, a steady growth in utilization. Of course, would have expected a lot more in terms of active membership.
Let me just finish out. Doc, I mean, we have 9 million active members who constitute this 35%, and probably that's the only those are the only population that are ill in the country. So if we rope in more, they will just be feeding the scheme with money rather than actually going to hospital.
Well, that is hypothetical. It is possible that that could be the outcome, but it could also be that the system might not be able to support if they all decide to make use of the services. And so, for me, it's something worth considering and thinking through it as we look into the next 10 years. I get the impression that you have somebody from the National Health Insurance Scheme in the studio, and I would like to suggest that.
Well, I have the CEO himself, Sylvester Mensah.
Oh, great. Yeah. One of the things that you need to really do is to strengthen their complaints and response mechanisms, because out-of-pocket payments are so prevalent, and sometimes at the time when the patient badly needs a service, is compelled to pay out of pocket when indeed he should be benefiting from the scheme. And so you need to have a system where even after I've paid under compulsion, where I don't have to pay, I'm able to complain to the scheme operators, and then they are able to also get back to me in good time with feedback in terms of what action they're taking on my complaints. You need to it only takes strengthening the complaint and response mechanisms to ensure that at least abuses are identified and addressed quickly.
Thank you very much.
I think that's a very useful suggestion coming. It's in the light of this that we established the call center. We have a call center currently that subscribers call when they have challenges. The whole idea is to provide voice to our subscribers who are a key part of this whole health insurance architecture, or within the tripod, that is the scheme, the providers, and subscribers. And we observed over the years that subscribers generally have been left off the hook, to the effect that they have nowhere to really voice out their challenges. And so we currently have a call center, and those who call this call center to complain have had attention. We have had situations where we have had to recover funds from some facilities for some subscribers, for that matter, and we would want to take advantage of this forum to inform all our subscribers to take a moment and call the call center in times of challenges. At the point of healthcare delivery, when there's a challenge, when there's a problem, when you are asked to pay, when you know that the service is covered, just call the call center, let them know the name of the facility.
Is it 24 hours or?
Yeah, it's 18 hours.
In 18 hours.
Yeah, it's an 18-hour call center. And our men and women at the call center will be very happy and ready to support. Those who have made the effort have had dividend, and we expect all those who face challenges at the provider end to call this call center.
There are a few people that I know that are not on the scheme because they simply can't afford it, and genuinely can't afford it. So what's the procedure they go through to say, look, I am really destitute and I need to be on the system for free?
Well, we have an exempt category, and the poor are exempted. The
So
truth is that, that we have observed that there are people who have difficulty going to the scheme to say that I'm unemployed, I don't have money, and so I should be exempted. That appears to be a cultural challenge, a cultural problem. But generally, those who have gone to the scheme to register and have indicated that, yes, I am not employed, I am poor, I don't have what it takes to make a contribution, would not be turned away. They would be registered. And we urge all those who don't have it, who are unemployed, and who genuinely cannot afford to go to the scheme and get registered. It is in their interest that we have a health insurance scheme. The idea is to save them from catastrophic health expenditure. The idea is to provide financial risk protection for that category of people who don't have it. A few questions will be asked just to ascertain that indeed you are unemployed and indeed you are unable to pay the minimum.
So in that case, they put you on the 7 CD scheme.
You pay nothing when you are poor, when there's evidence and you can adduce.
The scheme is from 7 cedis to 49.
A continuum between 7 cedis, 20 pesos, and 48 Ghana cedis.
48 Ghana cedis.
The poor who can afford pay 7 cedis, 20 pesos. The poor who cannot afford pay nothing. And that is the scheme that we have.
So if I have a 7 CD card or scheme, what do you get? I get up to malaria, or I get up to paracetamol, and then
no, we have a benefit package irrespective of how much premium you have paid. You are entitled to every benefit under the package, just like anyone who.
So if I turned up, you obviously charge me 48. Yeah, you look at my belly.
If I look 48. If I look at your chain, if I look at your watch, and I look at your glasses. You'll be between 40, 48.
You won't put me on 25?
No, I won't put you on 25. If I am at the scheme level, I won't put you on 25.
That's for another day. That's for another day. Anyway, Sylvester, it's been 10 years, and I think you guys deserve congratulations, because this is not the easiest of schemes. So I know I've been trying to bully you, but it's not the easy. If you put me there, I probably would not do as much as you've done.
Oh, you would.
So, we give you congratulations, pat on the back, and I'm sure, your guys would also want to hear congratulations from you.
Yeah, thank you very much. Over this period, we have tried to address the problem of ID card management by introducing instant ID card issuance based on biometric data. We are currently piloting electronic claims management and also capitation as a way of reducing abuse and fraud and injecting efficiency in our operations. These and many more we are putting in place to ensure that the scheme grows healthier and stronger.
Thank you very much, Sylvester Mensah, CEO, National Health Insurance Authority, and Dr. Steve Mantia of ISODEC also joined that on the phone. Congratulations. Let us all put our heads and hands together to make sure it lasts a lifetime. We will leave it for the generation behind us. My name is Nanan Saka. I've been watching PM Express, and as I say, tomorrow we'll be back to do it all over again.